First of all, I want to thank everyone for coming here today for the preceptor panel. As Dr. Whiting said, I am Ken Hiles. I'm the Associate Dean of Graduate Medical Education. I've been here a little over a year. A little bit of, very briefly, my history that got me to this position is I was in private practice in Southeast Arkansas for 25 and a half years, but was also a Director of Medical Education and Family Practice Residency Director in Southeast Arkansas. And after 25 and a half years, I was offered a position here for this job, and been here a little over a year now. Before I introduce the panel, I want to make a few introductions of some of the DCOM staff that are here today. The CME Director, Patty Stuberberg, Jody Caldwell, and Nancy Myers from the Clinical Med Office. We have the chair of our OM&M, Dr. Todd Dombrowski. Just saying hello. Introducing you. At ease. Chair of Family Medicine, Steve Miller. One of our clinical faculty members in Family Medicine, Jan Zieren. Let's see, who else? The director of our newly formed OPTI, the Tennessee Osteopathic Medical Education Consortium, Cindy Perry, and who am I missing? I think that's it. Randall. I'm sorry. Randall Batchelor, who's in the assessment office and has been key to the development of this program. Okay, on our panel, we have Dr. Sigrid Johnson. Dr. Johnson has a master's in anatomy from the Western Ontario University in London, Ontario. She attended medical school at the University of South Florida in Tampa, Florida. Did a residency at ETSU in Bristol. She is associate professor at the University of Tennessee, Knoxville, and is clinical adjunct faculty at ETSU as well as LMU DCOM. She practices family medicine at the Sweetwater Family Medicine Group in Sweetwater, Tennessee. Next to her is Dr. Linus Adams. He attended medical school in Guadalajara, Mexico, did his clerkship in Akron City Hospital in Akron, Ohio, followed by his residency in internal medicine, then did a GI fellowship at the University of Kentucky Medical Center in Lexington, Kentucky. He's an associate professor of medicine at the University of Tennessee in Knoxville. He was until 2002 when he left to go into private practice in Morristown and has been there ever since. Dr. Adams has numerous publications and lectures and has been very involved in research. He does practice gastroenterology, as I said, in Morristown, Tennessee. Next to him is Dr. Eva Stanzak. She's currently the Associate Professor of Pediatrics and Chair of Pediatrics at LMU DeBuss College of Osteopathic Medicine. Previously, she was the Assistant Professor and Discipline Chair of Pediatrics at the Edward By Virginia College of Osteopathic Medicine from its opening until August of opening in 2003 until 2007. Then she went into her own practice for a period of time. She was previously, before that, was in practice for 20 years, and for a short period of time also served as the chair of pediatrics at the University of New England College of Osteopathic Medicine. She's a 1983 graduate of TCOM, completed her pediatric residency at Children's Medical Center in Dallas, and by the way, was the first EO to be entered into allowed to do a residency at that facility. She currently is the chair of or president of the alumni board at PCOM, and she is also a graduate from the Costin Institute for Osteopathic Educators. Next to her is Dr. Kevin Purgill. Dr. Purgill is a graduate of Michigan State University College of Osteopathic Medicine, did his residency in general surgery through Michigan State University. Also, he practices general surgery at Highland Surgical Associates in Sparta, Tennessee, and has been extremely active to help support not only DCOM, but also the osteopathic profession and the students in the state of Tennessee. And at the end, not to be outdone, is Dr. Maurice Nida. Dr. Nida is a graduate of the West Virginia College of Osteopathic Medicine. He did his residency in internal medicine at Charleston, West Virginia, and he is duly boarded by the AOA and the ABMS. He's a former DME and residency director of the Osteopathic Internal Medicine Program in Norton, Virginia. Currently serves as DME and faculty for the Wellmont Health System osteopathic residency programs in Big Stone Gap, Virginia, and Kingsport. He's also a former chair of the Department of Medicine at Pikeville College of Osteopathic Medicine. He's got clinical faculty appointments and has lectured for LMU DCOM, Virginia College of Osteopathic Medicine, Pikeville College of Osteopathic Medicine, as well as West Virginia College of Osteopathic Medicine. And that is our panel, and I thank you all for being here today. We're going to try to be as informal as possible, so if you have any questions, feel free to ask at any time. This is being recorded so that we can put it on our website, so I would ask that if you do have any questions, the mic's in front of you. You just hold the button down on the end towards you. That'll activate the mic, and then it'll be easier to pick up the sound system in that way. The way I'm going to try to do this to be as streamlined as possible is I will ask, a couple of these questions I've actually put together into one, that we will ask, one or two of the panelists to respond to that, and then if any other panelist has anything to add, we'll do that, and then open it for questions, then go to the next set. If you have anything, feel free to ask it at any time. Like I said, I really want this to be informal and interactive. The first discussion topic was precepting in a busy practice. The first two questions I'm going to combine. That is, what benefits have you gained from working with students, and how has the students benefited your practice setting? Dr. Adams, if I could have you respond to that first, please.
Thank you. Somehow I knew that was going to happen. At any rate, the benefits I've gained from working with students, basically, it's just satisfying. I've been teaching in my own practice for about, in some fashion, since University of Kentucky, which dates back to 1983. So for me, when I left UT and lost that ability, actually we had a resident and a couple other people followed out of UT and came out and spent some time with me, but really for a short limited time, we didn't have students, didn't have residents. There was something missing, at least for me. So then I got to teaching the nurses and got into teaching the techs and got into teaching the other docs. I mean, there's three docs right now that work at Morristown that I trained as residents. So they get me all the time too, in their face pretty much. But the trick here was it was just satisfying, and it's personally satisfying. The other things that I've noticed is that if you can influence a student or a resident's life, in other words, a career choice or a way of approaching a problem, then you've left something behind. And for me, that's personally rewarding. It's nice to have residents come back and just tell you that, this is why I did this and this is why I did that, and you had something to do with that. So from my standpoint, on a personal level, it might be a little narcissistic, but it feels good. The other aspects of it is you've got to stay sharp. You can't slide. The students actually benefit me sometimes from reminding me of some of the basic sciences I forgot. Okay, so when they come at you as a third year, I get reminded. They actually teach me. But if they do that, they get it about tenfold in kind back. So it's a good give and take relationship. As far as what do they do in my practice, in all honesty, the patients don't mind. They love it. In fact, I get these weird belly pains from ribs and hips and all this kind of thing that people have been worked up, to the wazoo. I'm going to spill the beans, so if I get in trouble here, everybody can just shoot me. But if the students have had a manipulating ear, that anatomy thing you all do, I don't have a clue. I'm being honest, okay? But I'm impressed because my patients leave not having pain anymore. They also understand that it's not their belly. Okay, so God help, no more colonoscopies, no more uppers, no more surgeries, no more CAT scans. And I think I've been sending people to your clinic because of the students. Okay? So when you get somebody from me and said that Adam sent you, just kind of take care of them, okay? So anyway, that's how the students impact my life. They don't get in the way, they just follow. Okay? That's kind of what we do. I hope that helps.
I kind of have the same type of scenario that it keeps you sharp, and I just enjoy teaching. But when you was talking, I was sitting here thinking, what does it do for our practice? I have actually had patients get mad because they don't have the resident or the student get to see them. It just it adds a level to your practice as far as competency. And my patients, I find that anytime, or even out in the community, anytime you're a teaching clinic, you have students, it puts you at a higher level of competency, I think, than it does the normal practitioner. Not only does it do that, but the patients, my patients, thoroughly love being part of the learning experience. I've got patients who are trained that they know if they get a student that the student can't have their chart. They know what scenario to present to the student. And the patient satisfaction just goes tremendously high when you have a patient who can actually interact with the student during lifetime. And not only do I benefit, the staff benefits, the nurses benefit, but the most important person in the practice, the patient, they benefit from it.
Anyone else in the panel have anything to add?
Yeah, I do. Do I need to keep that button? I have a unique kind of thing. The word physician means teacher, not healer. And I love to teach. I figure I've been on this planet about 50 years now. So half a century has been devoted to what I think is the most cool thing in life, which is medicine, which I'm sure everybody else in this room shares. And when I try to take my little tiny Marcus Welby type practice and start talking about it, for one thing, the young doctors of this day and age don't know who Marcus Welby is. And so I dated myself right away. And when I went to the doc for the day in Nashville and tried to explain it to some of the medical students, they didn't know where I was coming from. When I went to the major teaching center at Knoxville and tried to explain it to the residents and the medical students, they didn't know where I was coming from. They didn't understand my practice. They didn't understand a family practice that is a lot like the Cracker Barrel to other restaurants' approach to medicine. I do about a third pediatrics, a third adult medicine, a third obstetrics, and home health, home visits, and nursing home visits, and that whole circle of life, family medicine. And when I tried to explain that out of my environment, it didn't work very well, and they didn't understand. When I went up on rounds at a big tertiary care teaching facility, I noticed that the residents, if they went into round on somebody and they had a cold or they had respiratory problems, they called the pulmonologist. And if they had heart problems, they called the lung doctor or the heart doctor. And if they had an infection or a fever, they called ID. And they never thought anymore, and they never really thought to themselves, how could I work through that problem? And down in my town, where there is no cardiologist, and there is an ENT once a week and a pulmonologist once a week, they have to and they have to hold people's hands, and they have to work through problems that are very multidimensional, kind of like what we were talking about when we were up on the third floor in the sim lab. You will get people that have 2 or 3 generations of problems that they come to within a 10, 15-minute visit. And how do you juggle that? And how do you also work through running a practice and all that kind of stuff? And to take that piece and teach it out of my environment does not work. Bringing people into my environment, they really get it and they see it and they get enthusiastic. Because more and more of your students come back and say, yeah, we do want to do primary care, and we do see how it works. Where they didn't see it on paper, and they don't see it on TV shows, and they don't see it in big centers and in other environments, but they do see it when they come to my environment. So. sorry. That's it. That's all I have to say. Okay, I'm sorry. Okay, sorry. It's my soft-spoken Canadian voice. I'm sorry. My kids don't think I'm soft-spoken, but in the real world, I really am. But that's all I had to say. And it benefits me. When I first moved to Sweetwater, back in the days before the internet became so prominent, there was no medical library. The internet was not so prominent. I was here like a lot of us were when Allscripts was free and Hippocrates was just starting out, and all these apps that are so prevalent were not so big 15, 20 years ago. And, you know, it's very easy to get stale, like some of the other panel members have mentioned. When you have young blood coming in and seeing things from fresh perspectives and showing the excitement that we remember that echoes what we feel in our heart, it keeps us young and enthusiastic in reading again ourselves.
If I can add just a practical matter to that, I agree with what everybody has said, but even on a practical matter, I have a very busy general surgical practice, and just having a student actually makes it appear as if there's more practitioners in the office. And if anything, it's great FaceTime. Patients are able to see somebody when ordinarily without a student they may be sitting in a room by themselves for a period of time. I'm a big talker, so when patients come and see me, they kind of understand, hey, Dr. Purdue's going to be talking for a long time. And it's just great having a student around that we can interact with patients a lot better. And I think the patient population loves that.
Dave, anything to add?
Well, I might as well put my 2 cents worth in, since everybody else has. I agree that having been a preceptor for over 20 years, I found that the students learned more from watching me in how I approached my practice and my patients, and even outside the office. They learned more from that than they did from any book they ever read. And because they came back and told me this, because I queried them at the end, I'm a big survey person, so I always made sure that they got something out of the rotation, and that's why I got into preceptor training a long time ago, because I wanted to make sure I did a good job. And I never found that the students slowed me down a bit for the same reasons that have already been spoken about. If you can send a student into a room to go ahead and start an interview, you can go see another person. And when you get done with that, you come out and the student's waiting to present to you. You really don't lose any time. I never had a patient not want to see a student. They absolutely love the students, and they wanted to know when the students left after 4 or 6 weeks, what happened to student doctor such and such? Where did they go? What happened to them? I miss them. Well, they went on to their next rotation, but maybe they'll be back. And some of them actually came back as pediatric residents. And actually, I had a few people come back and do an elective with me as a resident because they wanted to go into private practice. So that makes you feel good, and it keeps you on your toes. You can't get stupid when you've got students, because they're going to catch you every single time. And they're going to have a page number and a reference number and everything else. But if they see you operate and they understand how it works, there's no book they can go read about how an office works. So I think that part of it is huge and important. And you can teach on the fly, that sort of thing. And they get a lot from it because they told me, hundreds of them came back and said, wow, I didn't have any idea how a practice ran until I spent a month with you. So that, I think they got something from that, too, that they really didn't get sitting in a classroom.
All right, thank you. The next two under the first discussion topic, the questions, again, they're kind of related, so I will combine them somewhat. And then how would you overcome the challenges of having students in your practice setting? And one of the biggest challenges that we see not only in practice, but sometimes but not only in practice, but in the hospital setting, is how do you determine what patient care duties individual students can or should perform? Dr. Purdue's, I'm going to have you address that first, because yours is probably the most complicated area in that.
Well, and that's, I've had that question many times from other preceptors as to, well, what should we let the students do? I always approach it the same way when I answer that, is that, don't you remember what you wanted to do? I mean, that's the thing that we all have going for us, is that we've gone through it. And I think so many people forget about that. And the longer maybe that you've been out of it, it's harder to reflect back. But even as we were walking through the building, I mean, I looked at certain things and thought, oh, remember when I had to do this or had to do that? I think we all have that. So what I try to tell other preceptors and how I use it myself is, what did I find so amazing when I went on general surgery, or when I went on family practice, or when I finally got out of the classroom? And that's what you have to remember with the third years, is that they're just happy to not have to be in the classroom all day. And so when I look at what do I think that they're appropriate to do, well, no, I don't throw them in and let them do a gallbladder, obviously, but I do try to give them. I'm fortunate where I'm at. Before I came down to Tennessee, I was also in Michigan and still had a practice up there, and had interns and residents and students that came through, and also worked with them in the hospital through the residency program. And now down here in Tennessee, I do just have students. I try to give them that one-on-one with me, to try to tell them, go over certain things, how to sew. These are the things that we need to know on how to sew. Hey, that's a liver. Go through different anatomy. Any opportunity that I have to be able to say, hey, this is something. And obviously, I use them as a first assist in certain instances. But I'm always very careful to make sure I know exactly what they're doing. I mean, we don't necessarily give them the responsibility, but I give them the opportunity. And in the office, I send them in there. I said, here you go. You know, just like you do upstairs here. I say, the best thing, and I'll sit down when a student first comes to me. The first day, I'll sit down in my office and we'll chat, and I'll tell them I'm a big Michigan State fan, so obviously they need to know that. But the other things that they need to figure out is that, what can I teach them that, regardless of whether they go into general surgery or anything else, what can I teach them? I have 4 boys of my own, one of them sitting in the back, and I always try to, these kids are now coming through and like, holy cow, you were born after I graduated from high school, and they're getting to the point where it's like I feel like a father figure, where I have to hold, help them through. But I say the best thing that I could teach you, that you will use no matter what, is how to interact with patients, how to talk, how to speak, how to feel comfortable, how to just go in, how to knock on a door, how to just introduce yourself, no matter if the patient's 5 or 75. And so when we look at this, that really is not a challenge at all. I send them into every room. I tell them, you know what, by the end of this rotation, I want you to feel comfortable. If there's something that you're not comfortable with, we'll get through it. And I don't give them the responsibility of patient care, but I give every one of my patients is an opportunity for them to go in. So I say, listen, you're going into every single room. What I want, because I never show up on time to the office at 9. What I want when I show up, if they come to me and they're like, hey, I already saw this first patient, then I know I did my job. I think that that's a great opportunity. And of course, we go over everything else. But if that's kind of a roundabout way to tell you, it's there's no responsibility, it's opportunity.
Dr. Johnson?
I would agree. I think I look at it as they can decide where they want to be in medicine later on and narrow themselves down later on. Right now, in 3rd and 4th year of medical school, they should be doing everything. And the more they do, the better the doctor they'll be. Back when I trained, and I remember on my surgical rotations, they said if I was only on call every other day, I'd only be half the doctor I could have been if I was on call every day. Did anybody else train that way? And there is a certain element of truth to that. The more you see, the more normal, the more variations, the better you will be at whatever you do. When I was in medical school, we took, in preclinical, 2nd year medical school, I developed a project called Project World Health, and we took ourselves, preclinical medical students, to Colombia, South America, and they let us into the hospitals in Bogota and in the countryside, and we took off gangrenous legs, and we did do gallbladders, and we did do oral surgeries and deliver babies. And that's not something that we have the privy to do in America, but the people that do that kind of outreach or missionary work really have a flavor they can bring to medicine that is very, very unique and very well-rounded. And the more they can do, and the one thing I see in facilities I've been at where the students are not allowed to do anything, or they're the third person behind the central line, and they might see it from a distance, and they kind of wave at it, and that's the only central line experience they ever get. They don't know what I would like them to know. And it's not like every family doctor is going to need to know how to take out gallbladders or deliver babies, but if they know how to do it, when I went into the cath lab, I'm not going to be a cardiologist, but I can sure teach my patients what to expect when they go to the cardiologist. And I can explain to them in such a way that they won't fear going for their catheterization, and they won't fear getting their gallbladder out and all those things. And it doesn't mean that I want to be everything in the universe to everybody, but having seen it and being able to teach it and being able to expose students to it, I think makes them a better, well-rounded physician overall. So I try to get them everything and exposure to everything. When we deliver a baby, I don't want them to just be there for an hour or two. I want them to be there for the whole thing. Stay the night with me. Stay there for the labor, stay there for the delivery. Don't feel like you have to go home and check out at 5 o'clock and have dinner. And maybe in the future they want to have a practice that doesn't include call or doesn't include hospital or whatever. But don't do that now. Now is the time to do everything, because you're under our wings and we can catch you if you fall. But try and experiment and see and feel and touch and cut and sew and do everything now. And that's kind of what I try to get them to do. So kind of like you say, put them in the room, get them to do everything. Formulate opinions, formulate differentials. I like them to come into my room and come out and, not just have one or two decisions of why somebody's got a headache. Tell me the first 10 things or 15 reasons why somebody has a headache. And maybe most of the time it'll be a migraine, but maybe not. Maybe you'll find a subarachnoid bleed. But if you don't think it through, you'll miss it. And so if they don't see it and explore, and by the generosity of our patients, be allowed to talk to them and come up with all these things, and then they will never know that they can come up with these formulations themselves, and they don't have to shift people to other doctors or other professions or other avenues, and they get more confident themselves.
Anyone else in the panel have anything to add? Any questions? Yes, sir.
How do you approach your students to get them to think of the simple things first and not the complex zebras first?
Listen to the horses, not the zebras. Well, it's really hard when we go to round on our patients in the hospital and they're watching episodes of House on TV, because House is all about zebras, and it's really, really, really hard. It's hard for them to say. It's hard to say, hey, look, when you've got a headache, it may be a sinus infection, it may be a headache, and not have them go immediately to the subarachnoid bleed. But the caveat is they have to think of both. They're held to the standard of flying the plane, but also taking off and landing. That's the standard they're held to. So what I tell them is, you have to have your differential and put it common things common first. That's how we're trained. But don't forget, that's what will make you a better physician and make you not miss those things. I had a guy years ago that, when you raised him up, he dripped clear fluid out of his nose. When you flopped him back down, he didn't. And it's very hard to convince the insurances to let us do a CAT scan to show that he had air all over his brain and it was a CSF bleed and not just rhinitis. So I think it's hard to teach them because they don't know what's common. I guess it's hard to teach them common and then to also look for abnormal. And that's part of, I think, just exposing them to everything.
Yeah, I used to tell my students, and have a bunch of them, you have to learn normal first before you can know what abnormal is. And I was lucky in my own training that I got to see thousands and thousands of normal. I also got to see a lot of weird stuff, too. And actually, I had a practice that was 40% what I call zebras. But the cool thing about my practice was I always made sure that these students spent a lot of time looking at the normal children, and then I would put them in a room with a child with a 1p36 deletion syndrome. And they would come out and said, wow, here's the differential, and there'd be like 30 things on it. And I'm like, good, you're starting to think. But the beautiful thing, I tried to get them to think normal first, even though the person they were looking at was far from normal. I think it's just a matter of having them see a lot of normal stuff. And that bores us to tears if we have to see it alone. But what I've found over the years is I don't get bored with the normal stuff when I have a student. When I don't have a student, I'm bored to tears. I found that out in 5 years I was not in academics. But then when I had the students come, and it just happened last week, that we saw a normal newborn that had normal newborn things. And the student that was with me was just, you could see the little light bulbs popping on one after another. And I was just excited about it because that person was excited about it. And they came back and they just wouldn't shut up. They were telling me all these things. Oh, I heard that in the lecture that you gave and all this stuff. I'm like, wow, it is cool. So why do we do it? I think that's it. We're teaching normal. But the only way they can ever find the stuff that's not normal is that they get normal and normal and more normal. And then when the odd stuff comes, it jumps out and grabs them.
I think that just to add, I'm in a different kind of practice, being in surgery. A lot of times they only come up with the normals. So every time somebody comes up with a red herring, I'm like, all right, that's sweet, you know. But I try to encourage them. I mean, somebody comes up with right upper quadrant gallbladder or pain, they're always gallbladder. So I try to push a little bit more to try to get that. Maybe in GI we get that too, but you know, a lot of times I always tell them, don't let the skin interfere, you know. So we try to get them to delve into a little bit more.
Steve?
So thanks. When students ask that question, they're actually asking, what's the process that I'm supposed to be thinking about here? When do I think about the zebra as being a rational choice for the differential diagnosis? Sometimes it might just be a play for, hey, I know about this zebra, and this patient is exhibiting one or two symptoms of that zebra, and I want you to know about it. But then I can think about that. And the real question, though, is, what do I think as a doctor? How do you think as a doctor? How do you rule out a zebra, and how do you rule in that it's just common? So what they're actually asking with questions like that is, how do you think, and teach me how to think like you?
Just to add to that, that's one of the glaring things I see with the your students, support your students. And it's the thing that we impress, or I try to impress on. When they come, they can regurgitate facts. That's fine. But putting them together into a thoughtful sequence of events is a whole different ballgame. And what we emphasize, or what I try to emphasize to them, is how to think. And you got to think about everything. You got to think about the common things. You got to think about the uncommon things. But there are characteristics of them all, and putting them together and having it work for you. Taking a history is what I find extremely important for these young guys and gals to know. And it's one of the things they're lacking because they just haven't had the opportunity. And speaking in East Tennessee can be rather difficult to take a history. It's not exactly a Midwestern lingo. So you have to understand the colloquialisms and how people talk and how people interact and what they respond to. And it's all part of the same process, and I agree with you, Steve. That's the most important thing is, to answer your question, sir, is you got to get them to think. You can't get them to have facts.
And doing the history, like they used to say, is 90%. You know, sitting down and you'll know if it's a zebra or it's a common thing based on history. And you're right, you're getting them to just sit down and develop their history through is so important.
And if they throw out the Wikipedia, I'm all for it.
Yeah.
Any other questions? Okay. The second topic is promoting student learning. First question under that is, how do you determine and communicate your learning expectations for and to individuals? Some of this has been touched on peripherally. Dr. Stanczak, then followed by Dr. Johnson, if you could give us your approach to that.
No, I go first. I always asked the students when they came to the office, regardless of how many rotations they'd had, I would throw out a couple of just really common things. And again, I'm a pediatrician. They were scared to death when they came to my office anyway, because most of them didn't know anything about children, had never touched a child, and they were scared to death. And they were happy to sit and visit with me for a couple of minutes. I tried to find out what they had learned up to the point they went on rotations. And I asked specifically about their pediatric course, if they had one, and I also asked them what they thought they should get out of the rotation. I got a lot of very interesting answers over the years. Most of them wanted to learn how to communicate with children and their parents. That was the biggest one that I heard. And the other thing that came out of all these questions that I asked was actually a piece of paper that we would do at the beginning of the rotation that I called a learning contract. I was a teacher before I was a doctor, and I always felt like, as a learner myself, that if I had someone could help me with goals and objectives for what I was supposed to get out of anything, I would do better because I'd be looking for those goals and objectives. So basically what we did at the first day of the rotation was put together some goals and objectives, not a long thing. It only took 15 minutes maybe, of what they needed to get out of it and what I needed them to get out of the 4 to 6 weeks they were going to be with me, because they had to take a test at the end of the rotation and they needed to be ready for that test. So we kind of had an interactive conversation about what both of our goals were for the next 4 to 6 weeks so that we could meet them. In the middle of this time period, we sat down and had lunch, I was buying, and we talked about if we were getting there or not. Have you learned anything? What have you learned? And again, I stop people all the time when they're in a situation, they're explaining to me how they got there and got out of it, and ask them, what have you learned? And many of them look at me dumbfounded, but then they come up with what they actually learned. So this little learning contract worked very well. And at the end of the rotation, we were also able to sit down because I had to evaluate them, and I had to send something back to whatever medical school they came from saying if they did okay or not, or if they failed rotation, or if they passed, or if it was a high pass, or whatever, or if they were going to be pediatricians. So I had to have some way to judge that as we went along. And I don't like to get people up to the end of their 4 to 6 weeks and say, oh, you did a terrible job. They don't know what they did wrong. So that's the reason we developed Feedback Friday, which is something we did in our office, and we did it for everybody, not just the students. We had a little thing we went around our necks with a card, and we called it the F word. And we'd just randomly go up to each other and give them feedback about how they were doing that day. And it worked really well, and people started to get kind of excited about it, because not everybody had the card, and you had to have the card to be able to give feedback. And it worked really well. It sounds kind of silly and stupid, but in our office with a couple different providers and a whole bunch of staff, it was really effective. The students liked it. And at the end of the rotation, they were able to tell their department chair that they did receive feedback, not only from me, but from the other healthcare providers that were there as well as the staff, because I think the staff needs to have some kind of input as to how the student's doing. They're going to have to work with people for the rest of their life, and they need to learn how to interact with nurses and receptionists and whoever else you've got in your office. So that's how my little feedback form came into existence, because the students want that. And there's a right way and a wrong way to do it. That's a whole other hour for me to yak, and y'all want me to shut up, and I'll give it to Dr. Johnson.
Everything she said, and I have a 3-ring binder that I give them, and it has the STFA, Society of Teachers of Family Medicine, learning objectives as part of the things, and then I have a couple of psychosocial things. In my personal family, my sister years ago ruptured an aneurysm in her head and was on a neurosurgical floor, and it had bent me out of shape when she was called a head. And so I'm really big about the psychosocial. I talk to patients as if they're humans and not as if they're that part of the body you're working on. So I tend to do a little bit of that, and then I talk to the students when they first come to see me, because there's a lot of different things I can offer in the rotation, whether it's a rural elective or the family practice core, which I offer both. And the students that come to me come either at the beginning of 3rd year when they don't know as much, or at the end of 3rd year when they know quite a bit more, having been to all the other rotations. And also some of them come from various backgrounds, like they've been nurses or EMTs or something first, and they know a little bit about the healthcare environment. And some of them are super green and have never been anywhere near anything in healthcare their entire lives. So to match it for a very quick 4-week rotation, when I'm solo practice, I do have a nurse practitioner, we're going very fast all the time and do all these different things. In order for the whole month not to get away from us, we try to sit down at the beginning and I give them this binder and say, what is it that you would like from me? This is what I can offer you. This is what I think that would be important for you to know from my point of view, but I'm old, so medicine's changing. What is it that you would like to learn, or what is it that you think you need to learn? And part of it is real and concrete, and some of it is modeling, and some of it is sharing a style of medicine that not a lot of people have. A lot of the family docs now don't have comprehensive family medicine. So, but if they're going to work in rural health care, which is one of the very admirable goals around here, I think, is they need to know that they're going to actually be called to do a little bit more than dock-in-the-box stuff if you're out in the rural area. So the more well-developed they can get it leaving me after 4 weeks, the better I feel that I have helped fulfill my goal for them, which is having them see what it is like in a rural town, see what family medicine operates like, and in all its different permutations, and set them up for their next rotation, and have it kind of keep snowballing. So by the end of their entire medical curriculum, hopefully they've gotten everything plus this little piece from me.
Anybody else have anything to add?
Next question is, how do you build mentoring relationships with students? Dr. Naito.
That's something I think is not just done with one rotation. I'm lucky that I serve as a DME. Not only do I see these kids in my internal medicine practice and try to show them how to be a true clinician, how to diagnose disease states, how to get proficient in the diseases that we see the most of. But I also like it because I can also have exposure to them in the hospital. If I have an interesting case, I don't care if they're on surgery, I don't care if they're doing ENT, I drag them with me and say, look at this, what do you think is going on with this patient? Or if I'm up on the floor and I need to do a central line and we don't have a student, a fourth-year student on medicine, I may holler at the surgery student at that point and drag them into the room. So, to be a mentor to a student, to make it short, is to be available and show interest in that student. And show them what you know, what it's took 30 years of experience to gain. And have compassion for their area of learning, what stage of learning that they're in. Don't drag them in the room to humiliate them in front of the patient, but drag them into this room to actually have a true teaching point.
Dr. Pergel?
I agree with that completely, and I kind of alluded to it earlier. I'm kind of more of a paternalistic mentor, so to speak, but I am strong in encouragement. It is a matter of telling them, we sit down and discuss at the first meeting I see them how I expect everything to go, what my expectations are. They learn fairly quickly that I'm pretty open, that my life is an open book. I'm also very busy. I have a home life. I have a professional life. I'm also quite the character. I'm very well known in the area, and I think that the students, I take them under my wing, and they kind of go with me on everything. They learn what kind of life I have. I tell them everything, and I encourage them every step of the way. And I tell them, you're going to run into it. I give them philosophy hours. I just kind of go on and on about things, and if I'm irritated with hospital politics, I'll tell them. I'll sit there and I'll go into it, and I'll be like, listen, this is a bunch of BS. I let them hang out with my office. There's times when I have the philosophy hours. There's times where it's lose a student hour. I kind of send them off with somebody else for a little while, just so that they can understand what the circulating nurses do, what the nurses on the floor do, just different things to get them a little more of encouragement that they don't have to follow me around. I don't ever want it to be a follow around kind of thing. I want them to be my buddy. But I'm encouraging to them, and any time that I tell them down the road, if they've got an issue, they can call me, they can email me, they can text me. They all get all that information. I still have graduates that are texting me and telling me what they're up to and everything else, and I just try to be as open as possible to let them know that I'm not the professor. I'm, as they call me in the hospital, I'm more of the friend. You got a problem, I want to know about it in a professional aspect, in a life aspect, anything possible. And I think that that's how you build it. You can't do something in a month. But I think you can say, listen, here's the anchor. If you need something, just tug on it, and you can get somebody. And in a month, they know kind of what kind of a person I am. So I find that trying to build a preceptorship or a mentor role, someday down the road, they hopefully come back to the area, and hopefully they always remember me. So
I'm about to send, hopefully in the near future, after she gets done having this next baby, I'm about to send some of our students to one of my former students. And when I get back up to my office later today, I'll probably have no less than somewhere between 5 and 10 emails /text /Facebook sightings from somebody that I taught. And they come out of the woodwork at the most inappropriate times sometimes, but I never ugly to them. I always answer their questions. I've had them call me at 3 o'clock in the morning saying, Dr. Stanzak, I can't find my attending. This kid's crashing. What do I do? And I said, okay, calm down. Let's start again. And then again, it's a lot of life stuff. And I think if they find out that you're willing to share where you've been, not necessarily always professionally, but in your other life, I think that you have a friend for life. And I think you have as much or more influence on the way that they go. There's a lot more non-traditional students now than used to be. And I was one of the, probably not the first by any stretch, but I was one of the first crazy people that went to school with a bunch of children. And the people that have children find me somehow, and they come and they sit and they said, this is really hard. How do I do this? And I can't tell them what to do, because I don't give advice because I don't take it, but I sure can sit with them and listen to their troubles and listen to where they're going and make some comments and maybe even give them some tips on how to be more efficient. I think that's what it is.
I have 2 kids going through med school also. My wife's a nurse. I had my bachelor's in business administration. I was actually a stockbroker for several years, and then worked at Stryker Medical. So I think that I was out of it and came back, and you know what? I love what I do, and I think that it shows, and the kids love that. I always call them kids, but they love that. They can sense that. And when I had preceptors in the past who hated their lives. Every one of them were like, once they'd find out I was a stockbroker, all of a sudden all we talked about were stocks. Well, I want to do that. Stockbrokers got all the money. But they hated their life. Either it was HMOs, managed health care, whether it was time with their family, not time, everything. Now, and luckily I got out of residency before all the hours regulations, but then that came up, and everybody seems to think that it's miserable. And I wanted to give the kids a place where they could understand, you know what? If somebody is down, if they wake up one day and say, you know what, I don't know if this is it, that they can call me and I can help them. And I can say, listen, I love what I do. You need to love what you do. And if you need something, I'm here for you. Because I'll tell you, and this is kind of off the beat path, but we all, over the last 5 years, we've probably seen more and more lectures come around as far as the impaired physician. And I think that much of that, just like these hours rules, I have to inform the older surgeons. Those rules were not set in effect because of the young people. They were set into effect because of the older ones that abused it and had problems. That's why this came down. All of our governing boards, I'm board certified anywhere, all of our governing boards are not 35-year-old people. They're 60-year-olds who have lived through it and who have dictated that that's going to be beneficial. But, and I have to tell them, listen, we need to be careful about habits. We need to be careful about attitude. We need to be careful about certain things that may get out of hand very quickly. The divorce rates, the kids not seeing their parents. coming in, you got a huge workload. We all need to come into it together. And this has kind of been my method of saying, listen, I can touch each one of them as they come through. I can impose life lessons on them, but then always be there for them. And since I was in Michigan, I still have, they're calling me from Michigan. I do a lot of letters of recommendations. I've helped place a lot of residents in programs, in residency programs, but also in jobs. So, I kind of look at myself as more of a counselor, I guess, to these students, just trying to give them some knowledge here and there. But that's how I look at it.
So if you do something fun, invite them with you. I do ballroom dancing, and they're invited to come dancing with me one Friday night of their 4-week rotation, so that they can understand, especially in the female med students love it because they can see, I'm a female, I run a practice, and I have 3 kids and a farm, and I go dancing, and this is what we do, and this is my whole life. And somebody told me once a practice is like a jealous lover. If you give it a Friday, it'll take a Friday, it'll take a Saturday, it'll take a Sunday, it'll take, and it gives back very little. So what I try to explain to them is, hey, look, we can do this. Well, this weekend happens to be the Dancing with the Stars in Sweetwater weekend, so there's 5 DCOM students that are actually, some went last night and some are going tomorrow night to watch it. And they get to see how a whole town really rots down. So, and then they can see what it's like to be a community physician and to be supporting your community and to have a life and to do fun things.
We always took ours to all our bashes. If you were lucky enough to be on rotation with us, you get to go to the official Stands Act Memorial Day bash, and 4th of July bash. I put those students in the car with me, and we drove all over Dallas on home visits on Friday, and they got to see stuff they'd never seen before. I didn't, just because they were a student, they were only going to be there for 4 to 6 weeks, didn't mean they didn't. They became part of our office while they were there, and I think they all felt like they were part of us by the time they left, and a lot of them didn't want to leave. Can we do this another month? I said, I don't know, talk to your program director. But I'm like her, I took them where we went, so did the students. And we were foster parents for a long time, so these were foster medical students or whatever. And when we were up in Maine, other students would come. They would always send them to us because they always knew that they'd eat, and they'd have a place to be, and we made sure that they had their needs met if they were from far away.
Yeah. Same thing. We take them everywhere. I've had students cry that they had to leave. But I do that with a lot of, I'm in a small hospital now, and I do that with a lot of people in the hospital too. So there's many times when the whole surgery department will go off and we'll go do something, go out to dinner or whatever, and I'll take the kids, the students with me. The rule's always, no matter where I go, I end up paying for it all. So, they figure that's the give and take to working with me, but, that's exactly it. Maybe that's one of the qualities, later on when we get into it as to how we all ended up kind of in this position of imposing our thought process upon everybody else. But, I don't look at them as students. They're kids that have come into my life, and, they're like foster kids. And, I got several of my own. They're just one more, I tell them everything and try to impose things that they'll talk to me about later on. So.
Any questions at this point? Todd.
Again, you got a lot of great successes, but have you ever had a student that you just thought was just kind of a bad egg, and no matter what, you just couldn't polish that piece of feces, and what'd you do about it, what'd you learn about it, and how'd you keep from getting burned out?
Well, I was the great remediator from UT Southwestern Medical School. If they failed the pediatric rotation somewhere else, I got them. And that's not all the students I took, but if I had an opening, I got the student that had to remediate. So I got the ones that didn't make it. They flat failed. And I saw some interesting things. I got to tell you, in all the years that I've precepted, which was about, it was close to 20, I only failed, or actually asked to leave my office, about 3 students. And 2 of the 3 were from this group that had already failed. And I mean, they show up and they're not dressed appropriately, and they look like they're stoned. I mean, I had that kind of stuff. I've also had some students who said inappropriate things to my patients' parents, and also had students who contradicted me in front of the parents, and they went away. there's no screaming and hollering. I just pulled him out of the room and said, you can't do that. This is why. This is why you have to go back to your program director right now, because I didn't tolerate that. And I certainly didn't. And again, it happened very little. In fact, I think looking back on it, I'm kind of surprised it happened as little as it did. And maybe that's because of the way I do things. Some of the students who didn't do well in previous rotations absolutely had a personality conflict with the person they were rotating with, or they might have been with the preceptor who didn't want a precept. I didn't know where they came from. But they didn't. Most of them did very well for me. Some were a little. They weren't A students. They probably got a C just because they really had to be pushed to do things. But people who were absolutely awful and horrible, I didn't find that many. I made them go away right then. I didn't wait. They didn't come back.
My father was a teacher forever and a coach, and I always kind of looked at it as being a coach. Not everybody on the team necessarily gives their part all the time, and you can't have one approach to motivate everybody. I think that's part of it, and my dad always said teaching is not a passive occupation. You actually have to do something. You can't just grab somebody and have them follow you around and then say, hey, you got an A. And even on down here farther, how do you assess their knowledge and skill? Well, if you don't talk to them, you'll never be able to. And I think that a test shouldn't be the thing that determines, hey, they're great students or a great doctor. We know lots of great doctors who are not that test worthy, and I think and vice versa. And I think that those students that I find that way, that is like my paternalistic way. My kids will show up sometimes and not be all that happy, or I got a 20-year-old and down to an 8-year-old. So they're all going to be different, and they come in with something. I want to know why. What's going on with you? I'll confront them. I'll ask them. And I'll say, what is it? What is going on with you? That I understand that you may not want to be a surgeon. That's fine. But the first day I talk to them, this isn't to teach you to be a surgeon. This is to try to help you, let me impart my philosophy upon you so that you can be a successful person and a successful physician. So you're exhibiting certain characteristics that may not be successful for a person. We need to discuss that and go through that. And actually, I find, there aren't that many, luckily. But those that do, they may have other things in their life that, I'll open up to them and say, you know what? And especially, that goes back to my other rant about, impaired physicians, is that you got a physician that you're working with that necessarily doesn't treat patients very well. What do you do with them? I confront them. I say, listen, maybe it's my red hair, but I confront them and I say, listen, that's not appropriate. My mom didn't teach me that, and neither did yours. So what gives you the permission to do that here? And I think that that's what we need. And maybe a lot of times I've had a student in the past who just didn't know how to act. Nobody talked to him about how to act. He'd never been in that situation before. Or that he had a preceptor that didn't want a precept, that was more of a dictator, and said, no, this is what you do. And we all know that we've had some of those in the past. And to say, listen, I want you to come out of your shell. I want you to show me who you are. And I try to get rid of those barriers and try to get rid of that so that they can do it. Now, luckily I've never had any that I've had to say, yeah, you suck. But, I have had some that just, we needed to get through that. And I address it right off the bat, and I tell them when they come in. If I get any of these two, I tell them when they come in, you address them. I was in the business world, so first impressions are it. You got one time to make a first impression. You shake their hands. You always use, their last name. I still call patients Mr. and Mrs. So-and-so. I address everybody in the room. I shake hands with everybody in the room, even the children. With the kids, I get down on their level. I talk to them. With the older population, I show them respect. I'll tell them everything that they want to know about me, and you have to have a certain amount of flow that you can understand in order to get through that 14 minutes that we talked about upstairs. A flow to figure out who's the decision maker, who's a talker, are they feeling something with you that they don't like. I get the, hey, you look like my kid kind of thing every once in a while. Or, hey, you're a Yankee kind of thing, and then I go into telling them, well, my mom's from Tennessee, all that other good stuff. But, try to break down those barriers. But that's what I try to do with the students. I got to get them out of their shell. I just got to get them out of their shell. So I look at that as an opportunity. I look at that as somebody saying, something's not right, and I just address it.
As Nancy will fondly remember, a lot of times at our institution we call these problem children. And for some reason, our program attracted a lot of the problem children for some reason. But, as many years of precepting, some of these kids are just dealt a short stick sometimes. And all they need to bloom and to blossom is somebody to have faith in them and actually show them the right thing to do. And not to intimidate them. Once you get to the bottom of it, a lot of these kids have they may be scared, and incompetent in themselves. And once you instill, it's like, okay, it's all right to make a mistake, but here's the right way to do it. And once they feel like they can take a breath and not be intimidated, sometimes those are the best students that you put out. So, we take in a lot of those type of students and residents, but I think you can turn them around. Now, some of them, just have the attitude and the God complex, and I always look at them and tell them, look, you have not earned that right, and it seems like once you let them know that there is boundaries that they can't cross, there is a hierarchy to medicine. Just because, I can call a patient so-and-so, you need to call Mrs. so-and-so. And once they realize this, then sometimes they can turn out to be good kids.
Because they're just kids. That's right.
How do you assess the students' knowledge and skills? Dr. Adams?
That can be difficult, especially if you're trying to get them out of their shell. Usually what I try to do in the beginning is get an idea where they've been, what kind of rotations they've done, where they've got course. And the reason why it's important for me is I'm teaching them a subspecialty. I'm not teaching them general medicine. And so now all of a sudden we're at a different level, and I'm not trying to say anything by that, but the level of teaching that I will give them will be something more than this general medicine stuff and how you approach things, because my problem with patients I see are different. Okay, so from my standpoint, I have to talk to them. I have to ask them questions. I challenge them. I will continue to ask them questions till they don't know, and then we'll start lecturing. Okay? Because if they know something, I'm not going to teach them anything about that. So I just go ahead and keep on pushing them to the point where they don't know. Okay? And then I learn. And after dealing with students for 20, 25 years, you kind of get an idea of what they should know and what they shouldn't know at this level. Okay? And there's nothing specific about it. The way I grade somebody is, number one, and this may sound a little simplistic, but if you don't kill anybody, you pass. And if you show an effort, you pass. Okay? Those are the two things. Okay, now, do I let them kill anybody? No, I don't let them put in that position. So that's just a matter of a joke for us, and we break the ice. I think from what I gather from feedback from the students is that I'm firm but fair. Okay, and I do challenge them. I've only had one cry, and I really felt bad about that. I didn't realize she was that sensitive. That was in the first 15 minutes of talking to her. But I think she was set up by one of my colleagues to say, don't do this, don't do that. So at any rate, but she got along well in the month. Everything went fine. She knew what was wrong. But for the students that need more work, I tend to tone it down, and we start from the basics. Okay. For the students that are pretty well advanced, we tend to step it up a notch. So every month is different. That's part of the exciting thing. I've only had one student not respond, but he really didn't want to do medicine. He wanted to do hospital administration, just wanted to do something. So I think from a standpoint of how do you approach that, I don't think there's a way to approach that other than, just try to continue to challenge it and show them what we do. Okay? That's all I got right now.
Dr. Johnson?
I would agree, you asked. I get a lot of information when I have them go in on my new patients and do an initial history and physical and come back and tell me that new patient everything about them and the quality of the questions they ask and their ability to present it to me. Their ability to present differentials to me gives me a lot of information about what their mindset is. I've only had one patient, or one student I've been having a hard time with, and it's the one I had this last month, and she was sort of a problem student, and kept saying, well, I don't know what you want of me, I don't know, and would just throw up her hands, and that was a hard nut to crack, because I don't know if when somebody says they don't know, if they don't know because they don't care and they don't want family medicine, they don't want to be there, or they don't know because they really don't know and I need to start back a few steps and teach a little bit more. I find it much easier for the students that will interact back with me. The ones that won't interact back, which have been very, very few, but the ones that stay reclused in their shell that you can't draw out, to me are the hardest. Because you really don't know why it is they're holding back and for what reasons they're holding back. And if they won't engage in conversation, it's very hard to teach. And so that's been the hardest thing for me. And if I can just say, time out, let's just sit down and talk about where we've been and where we're going, and let's just really put it on the table and find out what is it that you're wanting. Sometimes that'll help me bridge that barrier and get through that. There's so many different reasons that people come in with their own personalities into a rotation and might be easier or more difficult to learn and to teach. That when you have to then evaluate the success or evaluate their knowledge base, it's hard to tease that out. Some people are easy. You can say, okay, you've been a student, you understand what a survey is, go do a survey monkey. Let's see what you know. And some people are chatterboxes, and I'm a chatterbox, and so we can chatter together till we both know what we all know. But for the people that don't and don't want to engage, I find that very, very hard. And the best I have been able to come up with is I ask my staff, because they observe that when I'm not in the room, I ask my patients. And my patients have been with me for 20 years. They'll tell me if they think that the person knows what they're talking about or not. I'll observe them when they're doing procedures. If they take off a basal cell or something like that with me, I'll observe their skill set, and I'll observe their interview skill set, and that's how I formulate as much of a basis for adjudicating as I can come up with. But it's not, in my experience, it's not a one-size-fits-all type of thing to do. It's very, very individual on the person that comes in on how they're going to do. If you show up and you have a pulse, it's very easy to pass the rotation. But to really get something out of it and pass to the level that I think that they should, to do justice to their level of training, what they want to do, and the money and time that goes into them, that's a different kettle of fish.
I actually had one come in 2 days late for a rotation and didn't call and didn't come by. And we thought we had a student that month, but I didn't know for sure, so I called the director and said, did you send so-and-so here? Yep, they're supposed to be there. I said, well, today's Tuesday. I still haven't seen them. They were supposed to be here yesterday. Well, Wednesday morning, about 2 hours after we opened the office, this person strolled in, feeling pretty sure of himself. And I'm like, well, hi, how are you? Where you been? And, well, I have this and this and this, and I just couldn't get here till today. Really? Okay. And then it never dawned on them that not coming and not calling might possibly be a problem. So I had to make, that's one of the three that I actually sent away. I said, we have to make different arrangements with this, because you've already missed 2 days. This is only a 4-week rotation. So you need to go talk with your program director, and we need to have you come back another time. And I picked up the phone and called somebody else and had a student the same day who didn't have a place to go. But I agree that some of these people are just very difficult to talk to. I have had a few over the years who wouldn't talk, and I talk a lot. I don't never meet strangers, so it's when I get somebody that doesn't talk, I'm really worried that there's something else wrong. And sometimes you're right. You just have to get it out on the table and go, okay, wait, this ain't happening. What's going on with you? You're in medical school, you're a third year, you're either extremely unhappy with the path you've chosen, or there's something else going on that's keeping you from being successful in your third-year rotation here. And we need to talk about exactly what it is. And I've had pretty good success with drawing people out that way. And as far as assessing what they know, if my rotation happened to be the very first rotation they ever went on, I could usually tell because they were like totally drenched in sweat when they walked in. But if they'd had a few rotations before mine, many of them were okay with the procedure of going to somebody's office and seeing patients. They just hadn't seen children. But the one that was his very first rotation, I said, okay, fine. Here you are. You've had something at medical school, and I already knew where they came from, so I knew what they had. I kind of had a basic knowledge of what they were supposed to get. And obviously, we all know that not everybody gets everything, so they may not have gotten it. And maybe that student really did remember what they were taught. I don't know. But I had to sit down with them and say, you can follow me for one day and watch what I do. And then tomorrow, you get to go to work. And I would ask them the next day, are you comfortable with this, going and seeing patients? And they'd either say, ooh, can I watch you for a couple more hours? Or they'd come in and go, yeah, I'm ready to do it. And most of them didn't have to follow me. There were a lot of them that were really scared. And they were like, but when they came out of the room after that first patient, they were like, oh, I did it. I can do this. I can actually touch a child. They didn't scream. And I'm like, I kind of picked that one for you. So sometimes you have to do that sort of thing so that you know that Johnny screams if I look at him. You don't want to send your third year student on their very first rotation to see Johnny because you know that they're going to come out and they'll be totally freaked out. So sometimes you have to pick who they'll see at the beginning because you know that person will be easier, and then you can give them the hard people later. That's how I did it.
I think that each one individually needs to be addressed. Yeah, every student that you get is going to be a little bit different than the last. Everyone is going to have a different level of starting and finishing. In my practice, I've got the office environment, I've got the OR, and then I've got the hospital. So usually between those three, I can figure out where a student is as far as their knowledge base, their eagerness. But I have to agree with Dr. Adams that, you show up, don't kill anybody, and make an effort, we're going to be just fine. And that's, I guess, when I see students, when they come in, I guess that's what I demand of them, is that you got to make an effort. You don't make an effort, hey, you need to do something else. Yeah, and that, yeah, exactly. With the kid coming 2 days late, it's just unprofessional. And if they make an effort, I mean, obviously in my head, everybody wants to do surgery, so I'm always, listen, let's get you into here, let's see how you do. Some of them just end up holding sticks the whole month. Some of them I've got closing incisions. Some of them I've got really doing things. And if they find a specific interest, hey, they're really doing well in the OR, they really have an interest in doing something in the OR, maybe I'll put them off on an orthopedist for a day. Maybe I'll put them off on somebody else for a little while so they can get a little more experience, rub a couple elbows with somebody else that might be able to help them down the road. If they really like the hospital, maybe I'll get them with a hospitalist if they seem to like that a little bit. Maybe the office, maybe I'll get them into a family practice for a day or so. I try to modify everything that I'm doing with the kids to give them the best experience. That's what I find is my satisfaction, is if they leave and they say, holy cow, that was amazing. It's like being at an amusement park. And that's what I try to do. But, through the whole process, trying to get feedback through them daily. Where are you at? What are we doing? Just trying to pick all that up. And also, like Dr. Adams was saying, find out where they're going, and then when they kind of run out of answers, that's where we really start talking about things. And some of them come in with no answers. Some of them get you pretty far. So I find it interesting for me also to just kind of have that banter as we go. So
Dr. Knight, you want to add anything?
I do. As far as the knowledge and skill sets of these kids, I think it's very important, like has been mentioned already, if they're coming out and this is their first rodeo out the gate, and this is their first month in the third-year rotation, I'm satisfied if they know to give an antibiotic, you know. But if this is the last rotation on the fourth year, I want to know which antibiotic they're going to give and why. So I think the level of experience that the kids have when they come to me is important. But I have a foundation of disease medical knowledge that I want these kids to have and possess. And I will quiz them to make sure that they do have that foundation. If not, is it a kid that's just behind, or is it the way it's been taught? I don't know. But, you know, every kid should know how to, in my practice, to handle diabetes and hypertension, or at least get the history that could indicate it as such. And I look for that in every student that I have. And if I find one that's way outside the norm, then I need to actually sit down with that kid and say, look, did you fail, did you fail pharmacology and cardiovascular system? Well, if they did, be honest with me, then I'll work with them to get them where they need to be. But I think it's the difference time of the year when you're getting them that you need to be sensitive to what level of your training they are and where not if they struggled in a particular subset of problems. So.
I can tell you that I think determining their knowledge base, trying to figure out where they should be, maybe has come a little easier to me having been in a residency program and had residents and interns and fourth years and third years kind of all at the same time, and you can parcel them all out. And that was really what you needed to do as an attending or preceptor, is to say, okay, this is what the fifth-year general surgical resident needs to be able to do, and this is what we need to know to the second-year general surgical resident, to the intern, who may be just a rotational or traditional intern, to the third and the fourth-year students, too. So, we always had to run around. We might have 3 different ones in the same room and had to parcel out everything and try to figure out, okay, who do I ask the question of first? And, I think that really has helped. That really helped me when I got started off into figuring out a foundation where I expect these kids to be. And when they show up in my office, I go over that. Listen, when you're an intern, you're going to need to know this, and this. When you're a resident, this is what you're going to need to know. Right now, you need to see ahead of you where you're going to go. And we need to figure out a plan to get you to that knowledge in the shortest amount of time possible, if that's indeed what you want to do. So, I just think that that's been a very helpful thing for me. So if you can't get that, then it's very difficult.
Dr. DeVros?
Have you seen a trend up or down in the medical school as the students come through and there's a certain trend, either positive or negative? How do you give feedback to that particular school, and how is it received?
If I may, I did pick up on the trend. Actually, when the schools first started, I was getting these third-year students who I felt should know more pharmacology than what they did. And I actually picked up on it that, it's like, for example, give an antibiotic. Well, which class would be best for this particular disease state? And these kids really couldn't go there. And it wasn't just one kid. I started seeing over 2 or 3 months, it was all of them. And I actually contacted the school and said, look, is there a problem? I've taught for 15 years. I'm really seeing these kids struggle in the area of pharmacology. And I was just real straightforward with the school to what I was observing as a clinical educator and what I was seeing, where normally I would see over 10 years, these kids should know these questions. And it was very much a lacking process that they didn't have the knowledge.
I think the last question in this set about the formal and informal feedback to the students, I think Pretty much everybody has addressed that in some form or fashion. Does anybody on the panel have anything else to add to that?
One thing, I hadn't realized until I had been precepting here for a while that there was a midterm evaluation form, and when I got that, it really, really helped, and the students are really, really liking that. 2 weeks into it, I just sit them down. In fact, one of them, the student I have right now, asked me to spend some time with her at the end of the day yesterday because it's 2 weeks in, and go over it with her before she finishes the next 2 weeks. And so they're really wanting that. And I hadn't known it existed for the longest time, but it really has been helpful.
About the only other thing, About the only other thing that I suggest is that about halfway through, get the student to evaluate you. Get them to evaluate your relationship. Are you guys communicating? Because everybody needs a little bit different kind of thing. Or where, now that they have a flavor of what you do, is it something else they want to concentrate on? So that you can hopefully address any other needs in the last 2 weeks that you need. Otherwise, just, not even involved.
Any other questions or comments for this topic setup?
Can I summarize a couple of things? I'm taking notes on what I think I use this.
Is that better? Okay. I started making notes on what I thought was important as a preceptor. I'm an internist in Kingsport. How do I get...
Just don't turn it on.
Just talk.
Just
talk
talk.
into it.
Yeah. No, just talk. It's fine.
Okay. So most of y'all have said all of this, so I just want to make sure it kind of gels in my own mind. First and foremost, of course, understanding where the student is in the rotation. That's obvious. First rotation, third year, and ending fourth year, two totally different units. But number one for me, get a good history, the patient interaction, understand the emotion in the room, all of that kind of stuff. That if you can't get that patient engagement, you're done. At least in primary care now, when you have a different kind of, if you're a neurosurgeon, you have to be competent. Anyway, number two, really learning the normals. I really think that you've got to do the same thing over and over and over. And I do my same exam on everybody, even if they're there for a side problem, do the same exam. Then abnormals just pop up, and then you know when you are looking for something. Three, be able to prioritize the problems. Some of that's easy when you know the patient, you've been seeing them for 2 years, but when they're thrown out of the room for 15 minutes on a patient they've never seen, it's not really realistic on how I deal in an everyday world. But, there's all these things that seem to be really important, and they're not. There has to be a priority in how you handle that. We didn't exactly talk about that. That's probably the only thing that I thought that I didn't hear anybody mention. The fourth one, synthesizing their knowledge of all these facts into some kind of relative importance. Every fact is important, but why do you use that antibiotic? Why do you want to look for this? Why do you want to look for something like that? What does that mean? What are the implications? When you look at an EKG, think 3 steps beyond. What are the implications of what you're looking at? In my practice as an internist, what to do about the particular situation, having the long view as opposed to the short procedural view that, my surgeon colleagues, they're going to say good all that, or they're going to come back to me. But their diabetes or hypertension or hyperlipidemia, all of that is the long view. How do I work through that? I have a very low threshold, and this gets into the practical actions of what they're going to do about the problem. I have a very low threshold for ordering an ultrasound for DVT because it's cheap and easy, and the chances of missing something is severe. But I'm not going to order a cardiac cath or a epidural or something or the other without having a pretty good reason. And I'll explain that to them and is that how you're thinking about some of these issues. And y'all said that, but I was just using that as an example in my own world. I'm really more concerned about them doing a drug class rather than you have to use Septin or 300 BID or whatever. I try to example teaching patients, and I didn't quite hear that one come out. I have a lot of information in my room and we go over a lot of the same stuff. And it's really refreshing to me when I come in, the student's already been talking to the patient, oh, I pulled out this and this, because I knew that's what you would give them, that kind of stuff. The exposure to other specialties when they show an interest. I've had one of my econ students who was interested in physical medicine and rehabilitation spend some time with one of our physical therapists downstairs who's just an awesome PT guy, and he really enjoyed that. We have a vascular medicine specialist in our office, giving them a little bit of a different exposure than the cardiologist would. We have somebody who does sports medicine, so they'd spend a little time with him. That's a different kind of thing. And we do a lot of clinical research, so they get a little bit of exposure to that. And I think that kind of makes it a little bit more unique when they might not get some of those things in other areas. So most of that I heard, but I just wanted to kind of synthesize it in my own thinking and bring that up for any other remarks or questions.
If I can speak just a little bit, family medicine and internal medicine do a lot of the continuity of care. When I have residents with me, they do a lot more continuity of care clinics. What I try to do with the medical students is teach them the flavor of continuity of care. So if they see somebody in the hospital, then I make sure that when they come back for follow-up after the hospital, they see the same person. Their eyes light up because they remember that person. And yes, we took care of their pneumonia, and now we're going to follow up from that. Or yes, they came in and and X, Y, and Z. And part of primary care is you don't usually see somebody for a focused 10-minute visit with one thing. And what I do in my clinic, I have a walk-in clinic Monday mornings because it bloomed from a totally solo practice, and people wouldn't see a doctor between Friday and Monday. And if I didn't have a walk-in Monday, there was nowhere to bleed off these patients. And so on Monday mornings, it's a 10-minute focused, one problem, that's it, no refills, no nothing. You're here for your sniffles or whatever. And then I do a lipid clinic and a diabetic clinic and a Coumadin clinic that are set up so that the mindset for the nurses and the clinicians can be more continuity along that line. And I try to make sure that when my student is with me, that Thursdays is diabetic clinic day. Well, they'll do 2 or 3 in a row of diabetic management patients, which is more holistic. And then once I feel like they've got that down pat, then I'll flip them to see somebody else. And I'm kind of monitoring who they're going in to see so they don't see too much of one thing. And if they've done 3 diabetics in a row, that they now do a well child visit or an OB visit or something, and so that they can then see the comprehensive nature of the profession as well, along with and for continuity, if I have patients that come back 2 or 3 times in the month, that's how they're going to get their continuity. Or when we see them, send them home from the hospital, how we're trying to send them home with discharge instructions that will throw into the future. What am I going to pick up on? They're newly diagnosed diabetic, or I had a DKA the other day that was newly diagnosed. Okay, so we've now controlled them. They're out of DKA. I'm sending them home. They're now going to go into this continuity clinic, and how is the thought process going to be moving forward? And that's how our teaching will change. And then the last piece of that is the prioritizing and the importance that you mentioned with the continuity of care. One thing that I try to get them to understand with our EMRs and our ICD-9 codes and all our coding billing issues, and where they're wanting doctors to be doing all this stuff that is a whole other profession unto itself that they've now added to our profession, is you'll see a patient in the room and they're wanting you to code, bill, have your correct ICD-9 code before they leave the room. So you're seeing your diabetic, is it at 250.1, 2.9? Is it controlled? Is it non-controlled? Does it have bad feet? Does it have hypertension? All this stuff. And that gets into what we're allowed to code and bill for and what level visit we get and whether we do a level 3, level 4, level 5. Well, in family medicine especially, you have to have 4 or 5 diagnoses per visit, and it has to be prioritized or it gets kicked back. Because your insurances don't want psychosocial, even though there's no psychosocial in my county, and I'm doing it. They don't want us to bill and code for your 300 whatevers. They want all the other stuff. So what we do is sit down with these. I try to get them to do their whole SOAP note and as much of an assessment as they can and stratified as much as they can. And then to complete the visit, where they would go with it, how would they code and bill it. And I try to not the first week, certainly, but at least by mid-time, like about now with the student I have right now, get them to start doing the notes as much as they can on our EMR and play with it, because whatever clinic they're in, they're going to be playing with a different EMR. And can they open it up? Can they work within it? Some of them will generate ICD-9 codes, some they don't. And so that gives a whole other breadth. And that becomes your prioritizing piece, I think. And it also becomes your continuity piece there. We just hadn't had a chance to talk to it. But I think that we all do it, but especially in primary care when you're doing so much breadth over long distances of time, that's how you can tease that in there. And in my clinic with my nurses, to get them to wear the hat, certain days are very nurse intensive, like well baby days when they're doing shots. If I have all my nurses doing shots all day long, then they can't do diabetic teaching. We can do one or the other. So we divide it. And so some of that division of labor at the outset with the students, I tell them, on Mondays we're going to have a walk-in, on Tuesdays we're going to have well baby, on Wednesdays we're going to do more OBGYN stuff, on Thursdays we're going to do our diabetic and Coumadin clinics. Having said that, that's our basic template, but we also do walk-ins every day of the week, so anything can be behind door number one. And so you have to kind of be used to that juggling of the hats, which is what primary care is.
Any other questions or comments? Okay. The art of precepting, what I'd like to do...
Yeah.
Oh, I'm sorry, Steve.
Thanks. It kept shutting off on me. So I'll have to remember that this is GH, so when student GH says it's shutting off on them, I'm going to have to believe them. All right. I agree with everything that you said and the comments that you made, too. And just to put it in my own mind together, it seems as if we're discussing two large groupings of skills that we want to see students perform. The first is the absolute fundamentals. Can they communicate? Can they do a history and physical? Can they recognize the absence of normal? And then the second grouping that we're talking about is those secondary skills that are important for our particular specialty or for medicine in general, whether that be billing, whether it be specific clinical skills or procedures, or how we think, helping students to prevent adopting biased thinking, anchoring symptoms to a diagnosis without fully thinking it through just because they've seen those symptoms before. But it just seems that those are the two groupings of things that we're actually talking about, and I've heard that each of the preceptors is assessing the students for those fundamentals first before getting into the more detailed skill set development and assessment.
Thank you. Under the art of precepting, what I'd like to do is kind of combine the two questions and then have each one of our panelists give a few minutes from their perspective. And that is, what are the key characteristics of an effective preceptor, and how have you personally become more effective precepting over the years? Dr. Knight, we'll start with you.
One of my favorite things about precepting, and how do you become an effective preceptor? And I've heard arguments, well, you let them present the H&P, no, you go in after them. But what I find that the students most enjoy the most is real-time feedback. My patients, and I think to be able to have students or residents, you've also got to educate your patients that they're going to be participating in medical education, and get their buy-in foremost before you can even teach a student. But anyway, once you do that, then I like giving what we call real-time feedback, that if they listen to a heart one way and I don't think that they really got what they should be listening to, I will correct them right then in real time. But I also love and I can't remember where it was published at, but they call it the 1-minute preceptorship, that every case, no matter how bland that they think it is, has a teaching point. Now that teaching point, depending on how well you know the patient, can be done in front of the patient, or sometimes it needs to be done behind closed doors in your office. Well, that's you knowing the patient. But I think the faster you can give real-time feedback to these kids, the better they like it. I don't necessarily like giving feedback at the end of the day where you've listened all day long, but you're not listening in the right place. But to me, that needs to be corrected at the time that you see something's wrong. And also, not only negative feedback, but I like to give them positive feedback. It's like, look, you really have a technique to draw out history. And let them know that, and let them to more refine that aspect. But I feel personally that the 1 minute preceptorship, where each case has a teaching point, where you give real-time feedback, be it good or bad, but not intimidate the student or not to make them feel bad is the trick to it. So.
Well, I think that much of that is true, and I always try to, every patient have a teaching point. I always pride myself on, one of my old preceptors had always said, in order to be a good general surgeon, you had to be a good internist. So I'll always try to bring up little things like, hey, did you see the clubbing of those fingers or whatever? And sometimes it'll catch my students off guard that, they're so focused on, hey, it's a gallbladder, they'll not look at other things. Or I'll have them come out with a history, and I'll go in and, the patient had a facial deformity from a car wreck or something. I'll go out and ask the student, so what happened there? And try to piece out different things to figure out, hey, how much did they really pay attention or get into that? But I think that every patient is a teaching point. And I enjoy going over every bit of that with them, and it's not always about surgery, but the characteristics of an effective preceptor, I think there's a couple things, 3 things that when I look at it, on one level, it's you got to be flexible. You can't be black and white in your approach to anything. You got to be flexible. Everybody's different, and if we haven't figured that out yet in medicine, that's too bad. But the other thing is patience. You got to have patience. Some of them are going to give you exactly what you want. Some of them are not going to give you anything that you want. And you just got to be patient to kind of work through all that. The other level is, as bizarre as it is, and as bizarre as my students may think that I am, I always have a control of the situation through the whole process. There's a method to my madness. And I think that whether they know it or not, or whether it's up front to them or not, there is, in my mind, I am leading them through what I want them to know and where I want them to go through the process. It's just not a blatant, out-in-their-face kind of thing. Luckily, being general surgeon, that first week, get to know them, kind of get them out of their shell, open them up, that kind of thing. But also, I hit the post-op stuff really hard. Every patient, I get quite a few post-ops, obviously, in the first week. They're going over these things. I'll hit that pretty hard. We'll start talking about some of the procedures, other things in the OR, that kind of thing. So then by the last week, the 4th week of the rotation, I send them into all the post-ops, and I have them come out and tell me what they're doing. I'm actually having them make some decisions. How's the wound look? Looks good. What do you want to do? Give them antibiotics or not do anything? Stitches need to come out, or whatever else. And I give them that opportunity to kind of take initiative and do that. So I think that helps build their enthusiasm and also their confidence. So to be an effective preceptor, I think it's very difficult, but it's obtainable for many people. How I've become more effective over time. In the beginning, I had residents, interns, students, and I was more dictatorial, more by the book. You got to know this, and this. If you didn't know it, off you go. Give me somebody else. And I've learned to be more flexible through the years and try to be more of what my father had said, more of a teacher rather than just somebody passive there trying to have these students impress me. I've gotten away with them trying to impress me, and I tell them when they impress me, but I don't look at it as the requirement. I look at them as students. I look at them as scared individuals coming out of 2nd year, going into 3rd year, and I try to get them on so that they're better prepared for everybody else and that they represent the DO profession and they represent humankind as well as they can. Especially DeBusk College of Osteopathic Medicine. I mean, being an osteopath, especially here in the South, it is a little different. Up in Michigan where I was more in a little warm community, and I try to impose on them, be proud of who you are. I only applied to one school. That was Michigan State's College of Osteopathic Medicine. If I didn't get in, I didn't get in. I figured that's what God said. I'm not going to get in. And I try to impose on these students, be proud of who you are. Be proud of what you represent. And don't be afraid to tell somebody, no, stand up for what you believe in. It's a life lesson. So that's what I've gone more to through the years, is trying to encourage better people, better physicians, and less by the book dictatorial, this is what you need to know for your test kind of stuff. So
I got asked a few years ago to address some pediatric department chairs across the United States about how in the world they could get preceptors to take their students. And they asked me to come up with the answer to this question. And so after some time thinking about it, I came up with about 10 things that you should look for in a preceptor. Not so much, maybe the one that you have to try to acquire for your own university or your own institution, but also looking at yourself if you were a preceptor. And some of the things I came up with, I don't have the list in front of me, but you have to be a good listener. You have to be extremely organized to be able to take this person into your office and teach them while you're practicing your trade. You have to know your subject very, very well, and if you have gotten a little rusty on a few things, you better go get unrusty because they're going to nail you. So you have to know your subject. You have to. You can't, and it's okay to say, I don't know, I'll go look it up. We'll look it up together. I've done that quite a few times, but you really have to be pretty knowledgeable about the day-to-day things. You have to have empathy. You have to have empathy for that person and their situation. You can't forget that you're a third-year medical student. Because if you do, you'll turn into that dictatorial person that he said he was a few years ago. You also have to understand that you have to understand the difference in people and the difference in the way people learn. Not everybody learns the same way. When I went to teacher school a long time ago, we were taught to teach the individual student, not to the class. Well, guess what? That changed in 1970. So you have to tease out how this person learns. And sometimes they don't even know how they learn, and this may be part of their learning that month. You also have to be very flexible, as he said, and you have to be able to roll with the punches. If they totally miss something, the way that you tell them that they totally missed it, there's a right and a wrong way to tell somebody they didn't do something correctly. If you do it the wrong way, you may alienate them for a very long time, and they may not be real happy with my next rotation because they're afraid of that kind of response. And probably everybody in this room had that kind of response at one point in time. I tried very hard not to do that. So learning how to tell somebody, hey, let's do this a little bit differently. I can't emphasize the patience enough because you have to never forget that they're students. They don't know anything about this. Some of them will come in knowing a little bit about how medicine works just because they had a medical-based job before they went to medical school. They still don't know how it works in a doctor's world. You have to be professional. They're learning from you. They're emulating you. If you're not professional in your office, they're going to know that right away. But unfortunately, they may learn from you as well. And one of the things I've had to tell students over the years is, if you're going to come work here, people don't know that you're not a doctor already. So you need to act like a doctor. I've already told some of the second-year students here now, you got to act like a doctor. You got to learn to think like a doctor. When is the right time to learn that? Well, it's like death and taxes. There's no good time, but you've got to do it because you're already here. You're halfway through. So I think those are some things that I think make a good preceptor. When I would go out and try to recruit preceptors, those are some of the things I looked at. And sometimes you can't see all those in the first visit, but you know what? If you look real hard, I bet you can.
I agree with everything she said.
I had two things for each question. What are key characteristics? Communication, which we've all spent all our time in our careers learning how to do well, and enthusiasm. If you don't love what you're doing, you ain't going to teach anybody anything about how not to do what you're doing. You just got to love. In this day and age, with all the problems in healthcare, you just got to keep loving it, and that love will shine through, and you'll be a good model and a good preceptor. And then the second question, how do I personally become a more effective preceptor? I don't know if I'm a good one or not. I self-assess, and every day I self-assess, and then I self-assess. And then you just keep doing it, and you 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 self-assess, and hopefully in there somehow you become a good preceptor.
Any questions, comments? Okay, I want to thank you all for coming today. There is up on the fourth floor in a few minutes there will be hors d'oeuvres, soft drinks, waters, and wine. And I especially want to thank the preceptors for their insight. Thank you.